You know, every single second, your body is pulling off this incredible, high-stakes balancing act. It's called hemostasis. It's the amazing system that stops a simple paper cut from turning into a disaster, but also makes sure your blood doesn't just, turn into solid sludge. Today, we're going to dive into how it all works and what happens when that perfect balance gets thrown off.
And that's really the heart of the matter, isn't it? It is a constant battle, this delicate dance between clotting up and keeping things flowing. If you get it wrong in one direction, you've got uncontrolled bleeding. But get it wrong in the other, and you're looking at life-threatening clots. So how on earth does the body walk this tightrope so perfectly?
Okay, before we really jump in, just the usual heads up. This is all for educational purposes. It is absolutely not a substitute for personal medical advice from a qualified professional. So here's our game plan for today. First, we're going to look at that big picture balancing act. Then we'll meet the emergency crew, the platelets. After that, we'll see how the body brings in the engineers to build a much stronger safety net. And finally, we'll put on our detective hats, learn how to crack the case using lab clues, and boil it all down to the absolute exam essentials.
All right, let's kick things off with that fundamental concept. Your circulatory system has two totally opposite jobs that it has to do perfectly at the exact same time all the time. It's this constant tug of war. On one side, you've got hemostasis, the power to plug a leak in a blood vessel like instantly. But on the other side, you have to maintain anticoagulation. You've got to make sure that life-saving clotting process doesn't just go haywire and clog up the whole system. If you fail at clotting, you get bleeding disorders. If you fail to stop clotting, you get thrombosis, things like a DVT or a stroke. Now, to manage this, the body has a really smart two-step plan. The first step is primary hemostasis. The best way to think about this is like the emergency first responders showing up and slapping a quick, temporary patch on a burst pipe. This is all about platelets. Then, a little later, secondary hemostasis kicks in. This is the heavy-duty construction crew arriving to build a permanent, reinforced seal over that patch. This is where the coagulation cascade comes in. Okay, so let's zoom in on those emergency first responders, the platelets. When a blood vessel gets damaged, believe it or not, they are on the scene within seconds. And here's how it goes down. Step 1 is adhesion. The injury exposes stuff under the vessel wall that platelets can stick to. But they need help, kind of like molecular superglue, especially in fast-moving blood. That glue is a protein called von Willebrand factor. Step 2, activation. Once they're stuck, the platelets totally change shape. They get all spiky and start sending out chemical alarm signals, basically shouting for backup. And that leads to step 3, aggregation. These alarms call in tons more platelets, which all pile on and stick to each other, forming that crucial first temporary plug. And here's why this is so cool and so important for us. Just knowing this helps us start to figure out what's wrong just by listening to a person's story. If the problem is with this initial platelet plug, primary hemostasis, you tend to get superficial bleeding. We're talking nosebleeds, bleeding gums, or those little pinprick bruises called petechia. But if the problem is with that stronger, deeper system, you see deep bleeding. Think bleeding into joints or big, painful muscle hematomas. The type of bleeding is a massive clue. All right, that temporary patch is in place, but it's not enough to hold forever. Now it's time to call in the engineers of secondary hemostasis. Their job is to build a tough, fibrin safety net right over that initial platelet plug to make it permanent. The absolute best way to picture this process is like a line of dominoes. It's what we call an enzymatic cascade. One protein, a clotting factor, gets activated, and its only job is to activate the next one in line, which then activates the next one, and so on and so on. The whole point is to take one tiny little signal at the beginning and amplify it into this huge, powerful response at the end. And the final domino to fall? That's the tough, cross-linked fibrin clot we're looking for. Now, this domino chain isn't just one long single-file line. We usually think of it as being organized into different pathways. The extrinsic pathway is like the initial spark that gets everything started. It's triggered by the tissue injury itself. The intrinsic pathway is this amazing amplification loop that makes the signal way, way stronger. And eventually, they both funnel into the common pathway to create the final product. And this isn't just boring theory. It's super important. For example, the classic bleeding disorder, Haemophilia A, is a problem with factor 8. Haemophilia B is a problem with factor 9. Both are key dominoes in that intrinsic amplification pathway. Okay, so we've got the theory, but how do we actually figure out what's gone wrong in a real person who's bleeding?
Well, this is where we put on our detective hats and use blood tests to find the exact spot where the chain is broken.
And this table is fantastic because it shows how a couple of simple screening tests can give us some major clues. We basically have two main tests that act like stopwatches for these pathways. The PT, or prothrombin time, measures the extrinsic pathway. The aPTT, or activated partial thromboplastin time, measures the intrinsic pathway. So if only the APT is slow, we start thinking about problems in that intrinsic pathway, right? Like hemophilia. If only the PT is slow, we might suspect something like a vitamin K deficiency. And if both are slow, the problem is probably downstream in the common pathway, or it's something affecting multiple factors at once.
But wait, this brings up a really common clinical puzzle. Let's say your patient's aPTT is taking way too long. How do you know why? Is it because they're just missing one of the factors, like in hemophilia? Or is it something more complex, like their immune system has made an antibody that's actually attacking and blocking a factor? How can you possibly tell the difference? The solution is this really elegant and clever little test called a mixing study. Here's what you do. You take the patient's plasma and mix it 50-50 with normal plasma that you know has all the factors. Now you run the aPTT again. If the time corrects, if it becomes normal, you know the problem was a deficiency. The normal plasma simply supplied the missing piece of the puzzle. But if the aPTT stays slow, that tells you an inhibitor is present. There's a blocker in the patient's blood that's so powerful it's now inactivating the good factors from the normal plasma too. So simple, but so brilliant. All right, let's bring it all home. Time to boil it all down to the absolute must-know high-yield patterns you need for your exams and for real-world practice. Let's lock in these key patterns. First, remember, the type of bleeding is your #1 clue. Superficial stuff like nosebleeds, think platelets or von Willebrand factor. Deep bleeding into joints, your mind should go straight to coagulation factors, like in hemophilia. Second, DIC. This is a nightmare scenario where clotting and bleeding are happening all over the body at once. In the lab, everything gets used up. Platelets are low, clotting times are long, and fibrinogen is low. And finally, the D-dimer test. Remember, it is great for ruling a clot out. A negative result is really reassuring. But a positive result can be caused by lots of things, so it can't rule a clot in by itself. You know, getting the science right is one thing, but we can't forget we're dealing with people. Managing these kinds of long-term conditions is a real partnership. And patients can have a hard time sticking with treatment for all sorts of reasons. Maybe they're afraid of needles. Maybe they don't fully understand why it's needed, or maybe they just feel totally fine and don't see the risk. And that's why this idea is so important. We've really moved away from the old-fashioned idea of compliance, which kind of sounds like you're just supposed to follow orders. The goal now is concordance. That means a shared agreement, a partnership between the clinician and the patient on a plan that actually works for their life. Because honestly, the most brilliant plan in the world is totally useless if the patient can't or won't follow it. So to wrap up our journey today, we've seen how hemostasis is this really incredible, finely tuned process. It starts with a super fast but temporary patch made of platelets, and then it's reinforced by a strong, stable fibrin net that's built by the amazing coagulation cascade. So what are the big things I really want you to walk away with today? First, always start with the patient's story. The type of bleeding is your biggest clue about what's going on under the hood. Second, use those lab tests like PT and aPT as your tools to investigate specific parts of the cascade. Your job is to connect the lab patterns to the clinical picture. And finally, remember that diseases like hemophilia aren't just facts to memorize. They are perfect real-world examples that show us exactly what happens when one little piece of this beautiful system breaks down.
And that brings us to one last question to chew on. We've spent this whole time talking about this perfect balance between clotting and anti-clotting. So what factors in our genes, our environment, our lifestyle, do you think have the biggest power to tip those scales, pushing one person towards bleeding and another towards thrombosis? It's a fascinating thing to think about. Thanks so much for joining us for this explainer.